Lupus nephritis. Patients with SLE variably presents with asymptomatic proteinuria and/or hematuria, acute nephrotic syndrome. Renal biopsy may show almost normal glomeruli, focal or diffuse proliferative glomerulonephritis, membranous nephropathy. Immunofluorescence shows mesangial and capillary wall deposits of immune reactants. Full house deposition. Okay, so like mesangium and the capillary wall. Usually on the mesangium there will be a deposition. But here it's full house, capillary wall and the mesangium. Anti-nuclear antibodies, anti-double-stranded DNA, anti-dsDNA antibodies are present in most of the cases with lupus nephritis. C3 is reduced. Remission and relapses and progressive renal damage are characteristics. Infections and end-stage renal disease are the chief cause of mortality. So இங்க வந்து சில points we are studying, okay? So lupus nephritis, the cause is SLE, systemic lupus erythematosus. They present with hematuria, proteinuria, which can be asymptomatic. They can present with nephritic syndrome, which can be acute. The renal biopsy can be normal or it can be abnormal. The abnormalities can be focal proliferative or diffuse proliferative or membranous nephropathy. Immunofluorescence will show mesangial deposition, capillary deposition of immunoglobulins. Antibodies will be there, anti-nuclear antibody ANA, anti-DNA, anti-dsDNA antibody will be there. C3 level will be reduced. Remission and relapse is characteristic. So, konja korayum, konja adhigamavum. And finally, the cause of death. The cause of death is because of an infection and end-stage renal disease. Infection and end-stage renal disease. Okay, so that's about lupus nephritis. Moving on to the last one, which is C3 glomulopathy. C3 glomulopathy comprises glomerulonephritis secondary to uncontrolled activation of the alternate pathway of complement activation, characterized histologically by predominant C3 deposits. C3 glomulopathy is called C3 glomulopathy because C3 is going to be excessively deposited in the glomeruli. In most of the cases, the complement dysregulation is caused by C3 nephritic factor, an autoantibody that binds to C3 convertase, stabilizing it against inactivation by factor H. This results in uncontrolled activation of C3. The patients usually show MP, which is membranoproliferative pattern. Okay, once again, C3 glomerulopathy. So it's glomerulonephritis. The pathology is uncontrolled alternate complement pathway is going to be activated. C3 is high. Complement dysregulation is there. It's due to a C3 nephritic factor. C3 nephritic factor is the villain here. It's going to bind to C3 convertase. Okay, so C3 convertase வந்து bind பண்ண உடனே C3 convertase becomes invincible. Okay, and then it will, okay, basically C3 nephritic factor is going to stabilize the C3 convertase. It will stabilize it. So it does not inactivate factor H. Factor H inhibit ஆகலனாக்கா C3 activate ஆயிட்டே இருக்கும். So the patients will show membranoproliferative pattern of injury, a lobulation of the mesangial interposition with thickening of the capillary walls. Okay, which appear as a split on silver methenamine staining. Okay, இது மட்டும் ஞாபகம் வச்சுக்கலாம். Split on silver methenamine staining. Immunofluorescence shows isolated or predominant C3 deposition in the GBM, glomerular basement membrane, in the mesangium and/or capillaries. Okay, C3 is in the GBM, mesangium, and maybe capillary walls. Electron microscopy, C3 glomerular is classified as dense deposit disease and C3 glomerulonephritis. Dense deposit disease la ribbon-like electron dense osmophilic materials in the GBM. C3 glomerular இது வந்து mesangium subepithelial or and/or subendothelial locations. Most patients present with proteinuria, gross or microscopic hematuria, hypertension or renal failure. Diagnosis based on renal histology and low serum C3, proteinuria, ACE inhibitors, mycophenolate mofetil,